Good afternoon and good evening. My name is Julie, dialing in from Sydney, and I have a group of amazing people here who have stayed up very late to talk to us. A group effort to talk about something that we're seeing increasingly commonly, unfortunately, a cardiorespiratory arrest in the baby with severe bronchopulmonary dysplasia, a very different type of scenario to your usual straight old cardiorespiratory arrest. So this group will be led by Dr. Brenda Law, who's a neonatologist from Canada. And they will do a group presentation with Dr. Monique Radman Harrison, who's a pediatric cardiac intensivist from Seattle, Dr. Summer Elshanawy, who's a neonatologist now in Atlanta, and Dr. Phil Levy, a neonatologist and a POCUS expert from Boston Children's. So as usual, we'll leave a couple of minutes at the end for your questions. But if you have anything that you want to ask the panel about during their talk, please type it onto the chat pane. And of course, at the end, happy for you to unmute yourself and ask any questions you want. We will record this meeting, but we'll check it to make sure there's nothing dodgy going on in the background before we release it to the wider community. So before we waste too much time, Brenda, the show is yours. Thank you, everyone.
Thank you so much. So on behalf of myself and my co-presenters, thank you for the opportunity to present on this topic. We have no disclosures relevant to this presentation. This talk is based on the work that we did together, putting together an article for seminars in perinatology on this topic, and you can find a link to the paper and a QR code there. As an overview, as a starting point, we'll discuss a bit on the definition of epidemiology of severe BPD, and then we will present a framework for acute care and resuscitation of infants with severe BPD, doing either an exacerbation or an arrest, based on three fundamental pillars, including the BPD phenotype, their phase of care, and acute pathology. We'll then go over our concept of an ABCDE framework for resuscitation of these infants, including airway, breathing, cardiac support, drugs, and ECLS. And finally, we'll present our vision on the multidisciplinary care and care planning for these infants, aiming for care optimization, exacerbation prevention, and the development of acute care plans. So first, we'll talk a little bit about...
One moment, Brenda. We can't see your slides. I'm sorry.
You can't see my slides?
No slides.
I see her slides.
Oh, do you? Okay, I just see a blank screen. Anyone can see Brenda's slides?
I see them.
I can. All right, maybe it's just me. Yep, okay.
Yeah.
No worries. Okay, keep going, Brenda. Sorry about that.
No worries. So as the base of our discussion, we're going to talk a little bit about what we mean when we talk about severe BPD. So as you likely know, the definition for grades of BPD have evolved over the years. Previously, such as those definitions from NICHD, have really utilized a combination of duration of respiratory support and an assessment of supplemental oxygen and a need for positive pressure ventilation at a certain gestational age to define BPD. And these include, for myself as a Canadian, definition used by the Canadian Neonatal Network. And there previously was a certain emphasis on a degree of supplemental oxygen. More recently, Jensen and colleagues have now defined a new BPD criteria based solely on the degree of respiratory support at 36 weeks post-neonatal age. Jensen's criteria listed here really have excellent predictive accuracy for a combination outcome of late death or respiratory morbidity, as well as late death or neurodevelopmental delay. It's also very strongly correlated with NICU length of stay and hospitalization costs. It does not define BPD based on the degree of supplemental oxygen, or usually previously less than or more than an FiO2 of 0.3. The population that we will be speaking on today are those infants who remained invasively ventilated at 36 weeks post-menstrual age. Having said that, the degree of illness in these infants will vary at the time of presentation to our units, from infants who are able to be discharged home on low flow and may come back for an exacerbation to those who remain ventilated via tracheostomy for several years. Unfortunately, BPD isn't going away despite our best efforts as neonatologists, despite sort of trying to optimize the respiratory care earlier on in the course of these infants. Recent data from Korea here demonstrates an increasing trend of BPD concurrent with decreasing mortality trends. These trends of stable or increasing BPD rates is really seen worldwide and maybe reflect a combination of either increased survival, increased resuscitation of those neonates at the periviable gestation, like 22 or 23 weeks. There are also some speculation on whether our increasing use of non-invasive ventilation support, respiratory support, may play a role. Various jurisdictions and hospitals have really differing policies on the care of these extreme preterm infants. My own institution I've only recently adopted a case-by-case resuscitation of infants at 22 weeks. However, as we pursue and are more successful with resuscitation of these periviable infants, we are seeing more and more infants with severe BPD who are now surviving to infanthood and beyond. The reality of these infants is that when they have severe BPD, they make up a significant portion of infants who are now admitted to hospital in general pediatrics unit or pediatrics intensive care or present to the pediatric emergency department. They are at very high risk for frequent readmission and late death. We don't really know what the incidence of cardiopulmonary arrest specific to the severe BPD population really is, and likely also differs by jurisdiction. But most importantly, most infants who do have an arrest do so from a primary respiratory cause, and this is likely to be true of infants with severe BPD. And so as we care for more of these infants who are now surviving to infanthood with severe BPD and they landing in our departments, we really in need of a framework to better care for them and a framework for how we're going to provide resuscitation for them. The framework needs to encompass not only that acute resuscitation phase, but also consider a more holistic approach includes crisis prevention, maintenance care, and a stepwise progression as the baby go from sort of more sick pulmonary status to going towards home, as well as the development of a tailored sick plan so that we can manage their exacerbations. Finally, when an arrest does occur, we would benefit from having a structured, systematic ABCDE approach that meets the unique needs of each SBPD infant. So we'll discuss all of these aspects, but first of all, we want to be able to ground our discussion on the three key pillars in understanding each SBPD infant when they present to us. So to understand all the aspects, we want to ground our discussion on what we think are three key pillars in understanding SBPD infants. The first is the phenotype. So there are very many different phenotypes, and this is central to each infant's BPD. The second is the phase of care, or where in the BPD journey they are in. And finally, the pathology of their acute on chronic exacerbation. I'm going to pass the torch now to Dr. Levy to talk more about these aspects.
Thank you, Brenda. So I'm going to start off by talking about the phenotypes. And for those who have signed on late, we're talking about the resuscitation of babies with severe BPD when they undergo an acute cardiopulmonary arrest. And we base it on the three pillars or the three Ps. The first is the phenotypes. So, and you can advance kind of the slides there, Brenda, to put them all up there. But basically, we know the lungs are intertwined with the airway and are intertwined with the heart and the vasculature. And when we think of BPD, it's no longer a yes, no, I have BPD. It's what type of BPD do you have? So most of our babies, if not all the babies with severe BPD, have an alveolar component. And I won't go into the differences between the old and the new BPD, but it's essentially there's alveolar damage, there's impaired alveolar development, and there's fewer alveoli. Then if you go down to the airway, there can be a large central airway component where we have malacia, subglottic stenosis, tracheal stenosis, or tracheal bronchial malacia. We'll hear more about that. You could have the small peripheral airways, the reactive or fixed, or the bronchoconstriction. Often terms, we think about this in pediatric of the asthma-like component of severe chronic lung disease. Then we have pulmonary vascular disease, which I'll speak about over the next few slides, but those are the babies who develop the severe BPD PH, and we'll look into the phenotypes. And then less common are the congestive or anosarchic, severely edematous baby, or the big puffy baby syndrome, and then interstitial, and finally there are babies who have very rare but interstitial lung disease or reflux. You can go to the next slide. And I really like the next slide because it's a picture actually from the paper, and we'll put up a QR code at the end, but it really talks about the phenotypes. You can see here there are 7 phenotypes listed. And then the white boxes within each one of these phenotypes gives you the management strategy from a ventilator and medication standpoint. And what we're trying to highlight here is that BPD, again, is not yes and no. It's what is the type or phenotype of BPD that you have. So again, just to re-highlight it, you could have the alveolar phenotype, which you're going to use a high tidal volume, long I time, low rate, and we'll talk about why in a few slides. If you have the Malaysic large airway phenotype, you're more prone to use higher positive and expiratory pressure with hypoxemia. The pulmonary vascular disease phenotype, which I'll speak on the next slide, and then again, the small airway phenotype, anasarchic, interstitial lung disease, and of course, please don't forget the infectious phenotype, where if a baby has multiple infections, those can cause the exacerbations. We can go to the next slide now. So just to highlight the pulmonary vascular disease, we're all very familiar with the term PPHN, or persistent pulmonary hypertension of the newborn. There's the early acute, there's the late acute. This happens early on, and it can even happen in our preterm infants, but we're going to focus more on the chronic pulmonary hypertension. That's either a classic rise in PVR due to that equation you can see there, or there's a left to right shunt from our classic nemesis, the PDA or an ASD, or there's left heart disease, either from systemic hypertension, which we learned a lot from our colleagues in Australia, and also from unfortunate disease states like pulmonary vein stenosis. So these are the hallmarks to understand the phenotype within the phenotype, because if a baby has classic PVR, you might give them nitric or sildenafil, but if they have left to right flow shunts, that may not be the choice of treatment in an acute exacerbation. More to come when we get to the ABCDEs. Let's move on to the next slide. So now we've gone from our phenotyping, which again, alveolar, small airway, large airway, pulmonary vascular disease, anasarca, to now understanding where are they in their phase of care. Are they acutely ill in the NICU in phase 1? Have they moved on to phase 2, recovery, chronicity, rehabilitation, where that can occur sometimes in a PICU, in a cardiac ICU, subacute care? And then how are they progressing into phase 3 and 4 with growth, health, maintenance, and development, and moving their way towards home? So let's move on to the next slide, and we'll go into a little bit more depth here. And here it's very detailed, and I'm going to leave it up for a few minutes in case those want to take a picture of it. But basically, there's phase 1, which is unstable. Phase 2 is transitional. Phase 3 is pro-growth, and phase 4 is convalescent. Let's just look at phase 1, for example. Multiple desaturations. You're getting some steroids maybe. You're on sedation, even unfortunately muscle relaxation at times. You have pulmonary hypertension or Malaysic spells. You have infection. So the goal in phase 1 is to capture proper sedation, kind of optimized ventilation. And then we go through each characteristic in that left column: your airway, your ventilation, your sedation, your nutrition, your development, and even your parental education. And that processes then goes from phase 1 all the way to phase 4. I'll show you an example on the next slide that Brenda will put up. But basically, here is just an example of FiO2. Phase 1 in a baby with severe BPD, for multiple reasons, you may have high FiO2 requirement. But in phase 2, 3, and 4, you can clearly see the FiO2 requirement dropping. But unfortunately, regardless of which phase you're in, where you are in receiving sedation or steroids or nutrition or able to interact with your care provider, you are at risk to have an exacerbation. And how you recover from the exacerbation depends on the phase of care and the phenotyping. Let's go to the next slide. So for me, when I put it together, the time to recovery, and you can hit the next piece of the story, both of them, Brenda, and the next one, thank you. The time to recovery following a crisis is much longer in phase 1 when you're unstable, but much less in phase 4 when you're in the convalescent phase. So that's important to understand. It helps you give your anticipatory guidance to the care providers and the family. And the most common causes of acute crisis are classic, what we call BPD spells, your loss of tidal volume. You could have Malaysic spells if you have the tracheobronchomalacia large airway phenotype. You can have a pulmonary hypertension spell. You can have multiple infections. So those are the kids that if they do have a tracheostomy, we do frequent tracheostomy changes, and we may even do inhaled tobramycin to prevent infections. You can have the mechanical backwalling, or you can have under sedation. Go to the next slide, please, and you'll be able to see that this is really highlighted. Another figure from our paper. All of you face this every day. In our NICU, we call it code brown. Those are when the babies have bowel movements that can then lead to an exacerbation or a crisis. But that's just kind of a joke. But here you can see clearly on the screen, highlighted in the big circles, procedures, airway obstruction, acute parenchymal disease, pulmonary hypertensive crisis, and even infection. All of these can cause acute exacerbation. And just as an example, an ROP exam, a G-tube placement, a hernia repair. You hear more about subglottic stenosis, loss of tidal volumes, the different phenotypes of pulmonary hypertension, and finally, multiple infections all cause arrest and the pathology of exacerbation. You can go to the next slide. So for me, when I put this all together, you're going to see this slide a few times. If you are a unit that cares for babies with severe BPD, I would highly value incorporating this into at least one note a week. You define the current phase of care. You talk about the phenotypes, and then you talk about the anticipated deterioration and the triggers, and all of this will help you overcome the acute exacerbations if you know what the trigger is. Go to the next slide, please. I'll hand it back over to Brenda to take us throughout the rest of the talk. Thank you.
Thank you, Dr. Levy. And so with that understanding, I think, of the 3 Ps, the phenotypes, the phase of care, and the pathologies, and having a good understanding of each unique BPD patient's journey and where they're at, we can then develop like care prevention, a maintenance approach, and at the end, we'll talk a little bit about our SIG plan approach as well based on all of this information. But before I go to that, I'm going to go in through our ABCDE framework, particularly for resuscitation, which highlights some of the systematic consideration of how we might tailor an arrest management for a BPD baby. So as an overview, ABCDE stands for airway, breathing, circulation, drugs and other consideration, and also ECLS. We do frame it in this order because for most babies with severe BPD, their arrests are often precipitated by a pulmonary reason. So I am going to go through, this is from our paper, but I am going to go through and highlight some of the key considerations in each one of these steps. So A is there for airway, and as Phil had kindly pointed out, infants with severe BPD may have a variety of airway abnormalities. We mentioned things like, tracheomalacia and malacia spells, or acquired subglottic stenosis, which are kind of 2 very different airway anomalies. They may have an existing airway, which adds to the complexity of the care, such as a tracheostomy or an oral ETT or nasal ETT. They may also have a dynamic versus a static condition in their airway. So that may also change your management. These factors really complicate how we're going to establish or reestablish an airway or maintain a patent airway or our initial ventilation management to kind of overcome any potential airway obstruction. So this is a really interesting imaging picture from a study out of Cincinnati Children's Hospital NICU, where they did MRI imaging from sort of infants with tracheomalacia. This is demonstrating that dynamic airway obstruction that can occur with tracheomalacia. This dynamic obstruction is very different than like a fixed obstruction such as a subglottic stenosis, and can really be improved with positive airway pressure, particularly that increased PEEP, and needs to be considered in the respiratory management of children with BPD in exacerbation or in arrest. And really that optimization of PEEP is really necessary to overcome sort of a BPD malacia spell that can occur and may also complicate how we reestablish an airway. There's also difficulty with reintubation. So both anatomical and sort of other reasons. Anatomically, of course, you have to consider, do I have an existing ETT or a tracheostomy? And reintubating a child with a tracheostomy can be very tricky depending on where the tracheostomy, where in the maturity of the tracheostomy is, and whether the tracheostomy was for long-term ventilation or to overcome an existing airway injury. There's also the consideration for, I guess, mentioned that dynamic versus static obstruction and whether maneuvers might be needed, including sort of ventilation maneuvers, increased PEEP, or actually physical maneuvers in order to maneuver an ETT back into place due to a static airway obstruction. A team also needs to be quite aware of the low procedural tolerance in these infants when they have a difficult airway combined with low pulmonary reserves. And also they may have a component of that pulmonary hypertension that can really be exacerbated by prolonged hypoxia and acidosis. And so even when you have the skills to reestablish an airway and have the adjuncts for emergency areas, such as like a video laryngoscope shown here, these infants really need an expert hand in reestablishing an airway and a good team approach. This is specific to managing infants with tracheostomy and how do we manage their tracheostomy emergencies. Having a very well thought out tracheostomy emergency plan is key to having safe patient care, no matter where they're being taken care of, either in the wards or in PICU or in NICU. These are a few examples of emergencies or cognitive aids and signs presented by Dorothy and colleagues that really serve as excellent examples of how we can have a team approach and a team understanding of how to manage either a new tracheostomy or an established tracheostomy. So next, I'm going to move on to talk a little bit about breathing or ventilation in these infants. As I already discussed, pulmonary exacerbations of various etiologies can often precipitate arrest in these infants who already have very complex lung pathology. And thus, optimizing ventilation management is often key to that successful resuscitation when they have arrest or a severe exacerbation. Why is it so hard to ventilate babies with severe BPD? I'm going to focus on the most common phenotype of BPD, was that alveolar, mixed alveolar airway phenotype, and not necessarily on the more rare sort of interstitial lung disease phenotype. And in these babies, the is because they have variable areas of lung and airway. So areas of lung that have low compliance versus areas of lungs of high compliance, area of the airways that may have high resistances or low resistances. And the challenge becomes we're trying to ventilate all these different areas of lung with one ETT or one tracheostomy or one mask airway and one ventilator or one manual ventilation, and trying to not hyperinflate areas of high compliance and low resistance, while actually being able to VQ match by inflating the areas of atelectasis. As a neonatologist, I mostly work with the newer preterm infants, and so oftentimes it's really hard for me to contemplate the ventilation strategies that's really needed for this established lung disease as compared to sort of the preterm RDS, early evolving lung disease pathology. So this is an actual time flow diagram from a ventilator from a baby with sort of evolving to established chronic lung disease. And it demonstrates why the low volume, high frequency lung protective strategy isn't really working for these infants. As you can see here, the inspiratory flow pattern is quite unique. There's an area of fast expansion early in the inspiratory phase. And then later on, in a relatively long TI, there's that later expansion of that more low compliance lung areas. Coupled with it's a low rate, which allows for a long expiratory time. This is the kind of strategy that works really, really well for that heterogeneous lung disease that we often see in the older infant with severe BPD. So me and my RT made a little bit of a two balloon model. It's a little bit of a arts and crafts to kind of demonstrate to my colleagues why this strategy really works. So the blue balloon is sort of high compliance, no obstructed lung. The red balloon is a low compliance and obstructed lung. And if we use a normal conventional ventilation strategy of sort of very fast rate, short TI, a standard volume, you can see that the blue balloon or the highly compliant lung expands very well. People's first move is to increase the PEEP, which could work very well for airway compliance issues and should be focused on. But in sometimes just doing that really only benefits one area of lung. The next part we want to do is to increase the volume. So as we do a higher volume, and by higher volume, meaning 8 mils, 10 mils, 12 mils per kilo, you start to get better inflation of the low compliance of the lung. But you also need, in addition, that longer inspiratory time in order to overcome that time constant needed for that red balloon lung. And finally, we want to make a couple more tweaks. We should make sure that we have a low respiratory rate to allow for us to deflate the highly compliant areas. And then the final tweak that we find really, really works for us is to make that volume much higher and then to increase the slope, to make a slower breath. So as you can see, we start to get more of that inflation of that low compliance lung area without hyperinflating the other areas. And you start to get better expansion, which then leads to better VQ matching, better oxygenation and ventilation. So when I present these kind of ventilation settings to my NICU colleagues, people really freak out about the kind of numbers that we're talking about. This is our local guidelines for established chronic lung disease or established severe BPD ventilation settings. And we're starting off at volumes of 6 to 8 mil per kilo, but really quite often going to 10, 12 mils per kilo and beyond in terms of tidal volume, and using quite high I times up to like 1 second. Some protocols and some in the literature even suggested using volumes of like 15 mils per kilo, although we rarely have to do that. The other part that really makes people concerned is using very high peak inspiratory pressures, and at times with the very severe cases, using PIPs of up to like 40 centimeters water and beyond. That can be quite uncomfortable when you're mostly in the early preterm infant lung pathology kind of physician. But these are the kinds of numbers that some of these babies need in order to ventilate their lungs. So what this means for an arrest is that you really need to understand the basic ventilation of a baby at their baseline based on their phenotype and phase of care, and as well as their pathology. And during acute exacerbation, understanding those 3 pillars, you have to develop a rescue ventilation strategy that goes above and beyond that. And oftentimes that means even higher PEEP to overcome any airway obstruction in Malaysia, higher PEPs and higher volumes, again, to overcome those BPD spells or that loss to tidal volume spells, and then a long TI and lower rate. So when you're manually ventilating some of these children in an arrest situation, you might have to have a very different strategy than what you would normally do for a code. Next, I'm going to talk a little bit about C for circulation or cardiac support. First thing that people think about, of course, is the chest compressions. And as we take care of children from sort of the early preterm in NICU to PICU in the wards, there's often a discussion of what the cardiac compression ratio really works for these children. There really isn't any data specific to the BPD population, but we need to understand that, of course, if their arrest is based on very much pulmonary exacerbation, pulmonary causes, then the ventilation component is an important part, as well as the chest compression to provide adequate cardiac output. All we can say is that the adequacy of the chest compressions is still the most important. That is to have a good quality, including depth and rate, and to use the protocol that your unit is most used to in terms of the chest compression ratio. The other aspect that we need to start stealing from our pediatric intensive care colleagues is the use of the addressing the reversible causes of an arrest, which is very much a part of PICU practice, much less so in the NICU. So those are what in North America we know as HNCTs, or the reversible causes. And I'll highlight some of them that are probably more pertinent to the BPD patient, including hypoxia and acidosis, and then of course, the risk of potential pneumothorax and other things like that. So we not just have to do adequate chest compressions, but also think a little bit about addressing those reversible causes. Another thing specific to the circulatory management of babies who arrest who have severe BPD is the consideration of how we manage things like a pulmonary hypertensive crisis. It really depends, of course, on what the phenotype of that pulmonary hypertension is, because for different types of pulmonary hypertension, the management that we use may make things worse or better, such as whether it's a left heart disease or a chronic left-to-right flow or that primary pulmonary hypertension that's secondary to that BPD. In terms of things that we can do, we can think about correcting hypoxia, acidosis of infection. We can use a sedation and muscle relaxation or paralysis. And of course, providing adequate circulation in the forms of Paxils and diuretics. The specific cardiac support also needs to focus on a couple key aspects, including the use of inotropes to support the right ventricle, which is under acute strain from that acute pulmonary hypertensive crisis, and the specific choice of vasopressors to manage both a combination of systemic hypotension, which then results in decreased coronary blood flow. And finally, based on the underlying phenotype of the pulmonary hypertension, we need to carefully consider the use of pulmonary vasodilators such as nitric, prostacyclins, prostacyclin analogs, and of course, the sildenafil and others, the phosphodiesterase type 5 inhibitors. I'll talk just a little bit about drugs before moving on. So as mentioned already, other than the usual kind of bolus epinephrine that we talk about in terms of code, we're thinking of oxygen as a drug, use of sedation and muscle blockade, chemical paralysis, the use of vasoactives, and of course, what we talked about already, the pulmonary vasodilators. We should also not forget the use of systemic steroids, as some of these children may have prolonged exposure to steroids as a part of their BPD management, and therefore at risk for relative adrenal insufficiency or adrenal crisis at the time of illness. So next, I'm going to pass the mic over to Dr. Radman Harrison, a pediatric intensivist, to talk a little bit about E for ECLS, which is not something that myself, as a neonatologist think about. And really my question that I have for her is, should infants with SBPD be ECLS candidates at all?
Hi, thanks. Yeah, I was tasked with specifically talking about ECLS in the setting of severe BPD. And so I'll just start out by saying, in this population, the goal of ECLS is to mitigate or avoid ventilator-associated lung injury as best we can. Brenda, I'll have you move to the next slide for me. So just want to talk a little bit first about anticipatory considerations and discussions with respect to these patients. I think first and foremost, a discussion about ECMO and eCPR candidacy is really crucial. And ideally, this would happen in a setting where there's not something urgent or emergent happening with the patient. Understanding that the workflow is different in the cardiac ICU where I work compared to the NICU. But in general, we do try to talk with our surgeons daily about our patients, particularly patients who are worrisome. For example, if they're not progressing or even having an exacerbation or a decline, a clinical decline like you might see with a BPD exacerbation. And really the question is, are they ECMO candidates? And knowing that ahead of time is super important if a patient acutely deteriorates. And it's not that uncommon that we might even say a patient is an ECMO candidate, but not necessarily an eCPR candidate. And that might be for a number of considerations. And so, factors that we talk about when we're having these conversations are, what other comorbid conditions do the patients have? Do they have known severe neurologic conditions of any type? Are they candidates for anticoagulation, or are there contraindications to that? What was the duration of any maybe pre-ECLS cardiac arrest or arrests that they've had in the past? And how long have they been on mechanical ventilation? And that's just, obviously to name a few considerations. And then, I think very importantly in there is family goals of care. And, ideally we're sitting down with these families again, ahead of time, not in the thick of an emergency, and asking them about that so that you have a clear understanding of whether ECMO or eCPR are things that the family wants to pursue for their child. Some things that we do that I find helpful is preemptive vessel mapping in these patients. This is a little, again, more, I'd say, pertinent in the cardiac ICU because of our population. But again, Dr. Levy brought this up, with BPD, we often see PDAs, ASDs, significant history of pulmonary vein stenosis. And we know that those patients tend to have already undergone cardiac surgeries, if not multiple catheterizations. They may have prolonged vascular access in the past. And so understanding if their vessels are patent, particularly in an eCPR setting, is really important. And so we will often, in patients we're concerned about, do preemptive vessel mapping. And we even keep a paper copy of that we update from time to time at the bedside. And then lastly is just the patient room arrangement. I know that sounds silly, but seconds matter for a neonatal brain. And so if you have a patient you're concerned about, arranging the room, putting the head of the bed of the baby out, moving things aside so the surgeons can very efficiently get in and cannulate in the setting of an ECPR. Those are just some of the considerations to bring up for these babies. The next slide. Thanks, Brenda. So indications for ECLS for these infants, there's kind of 4 broad categories that I wanted to talk about. So the most common being hypoxemic respiratory failure. These are patients that have severe, potentially reversible acute respiratory failure, and they've demonstrated a lack of response to conventional measures, and they've sort of reached the maximum of what we can provide in terms of medical management. VV ECLS is the preferred modality for hypoxemic respiratory failure. And when we start to think about this is when we start to see evidence of ongoing volume trauma and barotrauma. And one of the best indicators of that is calculating the oxygenation index. And so babies that are having an oxygenation index of 30 to 40, really you need to be sort of thinking about or pursuing ECMO or having the conversations that I already mentioned for those babies. And similarly, a mean airway pressure of greater than 20 on a conventional ventilator or greater than 30 on an oscillator would be kind of a time to maybe start thinking about that, or if you haven't already. And then lastly is a persistent air leak. So that again is indicative of barotrauma. So if you have a patient where they're requiring chest tubes for evacuation and things like that. I did just want to make a brief comment about hypoxemic respiratory failure. The presence of inotropes in those patients is not necessarily a contraindication to use VV support. Inotrope requirements are often reduced once you improve myocardial oxygen delivery and when you reduce the intrathoracic pressure. So they are still candidates for VV support in that scenario. That being said, I would say if you have a patient who is demonstrating severe shock that is refractory to multiple inotropes, you're doing all the things, muscle relaxation, sedation, they're on high-dose inotropes, even stress dose steroids, and they're still demonstrating evidence that their end organs are not adequately perfused, then that would be a situation where VA ECMO is a better choice. The only thing I'll say about hypercapnic respiratory failure is VV, again, is the preferred ECLS mode. I think it's rare to have that in isolation, but it happens. And ECLS, I would say in general, is much more efficient at removing CO2 than it is in oxygenating. So VV would be the better choice there. The next category of patients, of BPD patients with an acute exacerbation, is a patient with circulatory failure that's refractory to maximal medical therapy. And so again, VA is the preferred modality in these patients. And this is, again, the patient that's on multiple inotropes. Maybe they're making lactate or they're demonstrating evidence that their end organ perfusion is not adequate. And one word on that is, I would say, if you're putting a patient on VA ECMO and they have severe myocardial dysfunction, and I think the classic example of that would be a patient with septic shock, which is not uncommon in the BPD population. One thing to think about is if they have severe myocardial dysfunction where their ventricle cannot empty against the increased afterload that you're now giving them with the ECLS maintained arterial pressure and the presence of an aortic cannula, they will start to demonstrate some persistent elevation of end diastolic pressure. That is a possibility. And the way that manifests typically is edema on chest x-ray, pulmonary hypertension, maybe even pulmonary hemorrhage, and ultimately impaired myocardial recovery. So if you have a patient on VA ECLS and you are concerned that they have elevated left-sided pressures due to the increased afterload, in that scenario, left heart decompression is something you should think about. And that can be done either with atrial septostomy performed at the bedside or in the cath lab, or alternatively, a surgeon can place an atrial vent surgically. So something to consider in that specific population. And then lastly, septic shock, I'll just comment on this, is that historically it's been regarded as a contraindication for ECLS. But, you know, since the 90s, there's been study after study that's been published demonstrating really encouraging outcomes in those patients, in neonates and older children. So that is not a contraindication as it stands. Next slide. So when we talk about potential contraindications for ECLS, you know, there's the relative category and the absolute category. I would say more in the absolute category are patients less than 32 weeks or less than 1.5 kilos, recognizing that, you know, is a substantial amount of your population. And then I did put a star by lethal chromosomal abnormality. There are more and more centers these days that are considering patients ECMO candidates with known chromosomal abnormalities. And so I think that varies somewhat center to center. The other ones I think are pretty absolute: uncontrollable hemorrhage, obviously, irreversible brain damage, any recent intracranial hemorrhage, or irreversible organ failure. And then the next slide. So I included this. This is our center's eCPR algorithm. And what I'll say first and foremost about eCPR is that the survival to discharge rates, regardless of a patient's age, is still under 50%. And so I think that does underscore the importance of having these anticipatory discussions with the multidisciplinary team about candidacy for ECMO and eCPR. But I did just want to show you, this is our eCPR algorithm. So if, and this applies to our PICU, NICU, and CICU populations. And so if a code blue or green is initiated, which is really just dependent on where they're located, and a first dose of epi is given in a code, the charge nurse knows to ask the code leader whether a patient is eligible for eCPR. And based on these inclusion and exclusion criteria, if they are determined to be, then we would call eCPR. And so the inclusion criteria that we have for all ICUs is that it needs to be a witnessed arrest. There needs to be ongoing high quality CPR. There absolutely needs to be a secure airway. If there's not an airway, we are not supposed to call any CPR. And if there's a shockable rhythm, we need to treat that. And then obviously we need to believe that their condition is reversible at the time of the arrest. And then exclusion criteria, similar to the last slide, would be a terminal illness, an intracranial hemorrhage within the last week, and then ongoing hemorrhagic shock as the etiology for the arrest. And then the last slide I have, just to quickly talk about ECMO, is just wanting to show some ECLS indications and outcomes in this population. So these data were published in 2020. This comes from the ELSO registry from 1982 to 2018. And what this shows you is that the most common primary diagnosis in BPD patients was viral respiratory illness, 45%. And in BPD patients with associated pulmonary hypertension, most common indication was respiratory failure. And then there are reasonable survival in this population. So patients with BPD, or I should say infants 2 months to 1 year, have a survival rate of 66%, and patients with BPD and associated pulmonary hypertension have a survival rate of 83%. So fairly reasonable. And I think it's back to you, Brenda.
Thank you so much for that overview of ECLS. I'm going to hand over now to our last speaker, Dr. Summer Elshanawy, to talk a little bit about our multidisciplinary approach to the care of these infants.
Yeah, thank you, Brenda. So with the time that I have left, what I hope to do is sort of pull together everything that's been discussed to think about pragmatically, how do we approach the care of the BPD, severe BPD infant, especially through the different phases of care and as they have acute exacerbations. What can we do as a multidisciplinary team to anticipate, prevent, and then respond in a systematic and timely way to prevent further deterioration for the patients. So we saw this slide before, and it's going through those different phases that you've heard, including prevention, maintenance, having the appropriate sick plan approach, and then thinking about the framework for resuscitation. So we can go to the next slide. So if we think about the care for a patient with severe BPD, on all levels, we need a multidisciplinary team to really provide the ongoing care for these patients. These patients are complex. They're in the hospital for a very long time, and their team over time will grow and grow. And it requires alignment of that team in the care for the baby and for the family, because these families go through so many ups and downs and challenges, from delivering a baby very early, potentially unexpectedly, to these long hospitalizations, and being able to provide that support in a multidisciplinary way is critical to having that alignment. And it's been shown to actually improve outcomes. We can go to the next slide. And the goal of that is really just to optimize the positive influences that promote progress and growth, and also to minimize the things that set babies back. So things like infections and acute decompensations. So this is a slide that Phil put together that I really like, that basically indicates that getting early engagement from the BPD team as early as 32 weeks, when you see that those babies are evolving the chronic lung disease, and having that interdisciplinary team involved throughout the baby's hospitalization and through discharge and transition to home is really critical in optimizing the success for these babies. Next slide. So to carry that framework, how do we approach the severe BPD patient who is at risk for acute decompensation? And the important thing is that these individualized care plans exist for these patients based on what we talked about: the phases, the phenotypes, and the potential causes of their arrest. And the idea is not just to build it in a silo within one discipline, but to build that collaboratively. And the purpose of that collaborative plan is to create a shared mental model. And the idea is that everybody caring for that baby, from the bedside to the consultants to the providers, are all aligned with how to address the concerns that come up for this baby in order to anticipate and hopefully prevent a decompensation. And this shared planning can improve handoffs, it can improve rounds and escalation preparation, and ultimately, if you're unable to prevent the decompensation, that crisis resource response. So the things that Dr. Radman Harrison was talking about, with even preparing for ECLS, or knowing, is this patient an ECMO candidate or not? Or how am I going to address the ventilation strategy for this patient? So that shared mental model is critical, because the bedside nurse and the respiratory therapist can know what the triggers are to alert the rest of the team sooner and respond appropriately. Next slide, please. So this kind of goes along with that. So understanding, again, what is my phenotype and what are the things that may trigger an acute exacerbation or acute decompensation, and informing, having a discussion with the bedside team to allow them to have earlier recognition of a clinical deterioration. This is where you can, and the next couple of slides will show you the actual application of that. You can implement a sick plan. You can say, this is how we're going to escalate care to prevent further decompensation. Recognize this patient as a watcher for your unit, however that is identified, and closer monitoring and closer follow-up from the entire multidisciplinary team, tailoring the resuscitative actions to the patient. So understanding it's not just about NRP versus PALS, but what kind of ventilation strategy. Is this baby prone to clamp downs? And informing your team that you may not want to pull the ET tube right away, understanding it may be a difficult airway or may have poor pulmonary reserve. So gearing your team towards understanding what kind of ventilation strategies do I want to use to try to overcome obstruction before making other decisions, like pulling an ET tube or initiating chest compressions without really establishing effective ventilation. And then that can help with role clarity and resuscitation planning. So again, An effective resuscitation is one that is run systematically. It includes high quality CPR, and it includes a team where there is good closed loop communication, role designation, and all of that is important to anticipate. And I think each of the prior speakers talked about anticipation, and this kind of pulls it all together. And this vigilance is what can really allow the team to respond appropriately. Next slide, please. So as you think about a pragmatic tool that you can use, and this was actually inspired by the PC4, the Pediatric Cardiac Critical Care Cardiac Arrest Prevention Bundle that was shown in quality work to actually improve outcomes and prevent decompensation. So along the same lines, thinking about for the severe BPD, what are ways that we can anticipate and prevent cardiac arrest and prevent decompensation? So it summarizes, as Phil described really nicely, summarizes the patient's status, phase of illness, the phenotype, and the triggers, and then actually gives you actionable rescue strategies. So not just what do I think is going on with this patient, but what would I do to respond? And then having a phenotype-guided resuscitation table that can actually guide your resuscitative intervention, and this is all included in the paper. And then having a checklist and early warning system to identify these patients early. Next slide, please. So this is an example of what that could look like, and understanding, again, the phases, the phenotypes, and the potential triggers, which we've already talked about, and actually using this as a pragmatic tool at the bedside for your patients that's discussed regularly, and again, in a multidisciplinary way, so that everybody on the team understands what the progression of disease could be. Next slide, please. And then here, again, is a way to create that shared mental model by listing things like the airway, the ventilator strategies, and then some of the recent information that may inform care at the bedside. And the next slide. And in the acute management plan, this, again, the goals of care are listed at the top, so everybody knows, what the plan of care is for the patient. The rescue therapies based on the type of phenotype are also included there. And being able, again, many of our patients may overlap with multiple phenotypes, but knowing what's worked for a patient in the past and knowing how the patient has progressed, you're able to at least guide the team in that. And then having that at the top, the ECMO candidacy, having that be a conversation, a proactive conversation, so it's not a decision made as you're giving your first dose of epi, it's something that is already defined for the patient. Next slide, please. So I'll pass it back to Brenda.
Let's just do a quick wrap up here so I have maybe a few minutes for discussion. We have a couple key messages. More infants now are surviving with severe BPD and being cared for in a number of environments, but it is a complex and heterogeneous entity as demonstrated by our discussion for that, based on the three pillars, based on this phenotype of the BPD, phase of care, and as well as acute pathology. We outlined a bit of an ABCDE type framework, highlighting key consideration for the resuscitation of infants. And more importantly, as Summer mentioned, that multidisciplinary care of these infants can help prevent arrest and optimize care when exacerbation does in fact occur. And so hopefully we have a few minutes for discussion.
Thank you very much. What a smooth team. Look, we do have some questions on the chat. And I think the first two questions are sort of aligned with the same theme. Kurt's asking whether we have enough clinical diagnostic tools to differentiate the various types of BPD. And Dimple from Western Australia is asking, how do we get an airway or chest CT to see what type of phenotype the baby has? Who wants to take that one?
I'll jump in and take that one. That's I can do that. So again, just most of the babies, if not all the babies who have the severe BPD, are going to have the alveolar phenotype. So usually you can make that diagnosis clinically and with a chest X-ray, and that alludes to the high tidal volume, low rate, high I time strategy. if a baby requires higher positive end expiratory pressure, usually when they get above the 10 to 12 range, and they're having signs and symptoms clinically based on how they synchronize with the ventilator and also the malastic spells, that's when you would do further investigations. Some centers will use a dynamic CT. Some centers will do dynamic bronchoscopies and look at PEEP titration. So that's really focused on the tracheobronchial malacia. In terms of the pulmonary hypertension phenotype, it's basically standard of care at this point if you have severe BPD to obtain an echocardiogram as a screening modality to look for evidence of pulmonary hypertension. We know that it may not find all the phenotypes, so if your degree of oxygen support is out of proportion, then that's when you may move on to a CT or some other modality to be assessing for pulmonary vein stenosis or other areas of pulmonary hypertension. The infectious etiology, well, that's just clinical acumen where they're getting multiple infections. Very rare to have interstitial lung disease, but if you get to the 40 weeks, 44 weeks, and they're still on respiratory support out of proportion, we do advocate for sending ILD, interstitial lung disease testing. And then on the very rare occasions, there are a few centers, for example, Children's Hospital of Philadelphia, where they're very attuned to looking at lymphatics in the very puffy baby syndrome. So again, that gets into the very weeds and the zebras, but it's a stepwise approach to looking at the phenotypes from alveolar, small airway, large airway, pulmonary hypertension as the four most common types.
Thank you. How do you get these kids down to CT if they're so critically unwell?
I can let Monique chime in, but oftentimes with sedation and optimization of all the other pieces of their puzzle, from nutrition, sedation, sometimes muscle relaxation. But Monique, who will take the sickest babies in her CICU on ECMO down to the cath lab, these are doable. So, but it takes coordination. That's basically Monique's point, that she's highlighting.
We'll have one of Monique, please.
Yeah.
We'll have a few of you.
Oh, you're so nice. Thank you. Yeah, I agree with that. I mean, I think it takes a lot of coordination and a lot of safety measures for sure. And just a lot of hands. A lot of hands.
Lots of hands. But that's probably part of your routine workup for a baby in trouble, right?
We often will send babies to CT. We do have patients where we say, this patient is too sick to move right now. So that does happen, but in general, if they need a cath or they need a CTA, then we will do our best to find a way to get them there, safely. Yeah.
Thank you. Look, there's a question from Kurt who asks if, do you mean ECLS possible in babies? So PV stenosis, Kurt?
I think I read that. He looks like he's asking.
Where is he?
If you can put them on ECMO, can you put those babies on ECMO?
Oh, absolutely. Yeah. So patients with PVS. So, both modalities of ECLS will support a patient with known pulmonary vein stenosis. If you think about it in the setting of VA ECLS, you're actually reducing the total pulmonary blood flow. And so you're actually bypassing the area of obstruction and in some ways potentially making things better. So that's not really an issue. If the patient has a severe BPD and an acute exacerbation, presumably that's not related to their pulmonary vein stenosis. We don't usually see that where they one day are okay and the next day they're needing ECMO. And so if it's an acute exacerbation of their BPD, for example, with an acute infection or something like that, we can support them on VV as well, knowing that they're still getting quite a bit of pulmonary blood flow. If while they're on ECLS, we need to take them to the cath lab for an intervention on their veins, and that is absolutely doable for sure. Yeah.
Okay. And probably in the same vein, Dimple's asking what's the average duration of ECMO for a BPD? That's often considered a worry with decannulation.
That's a great question. I don't know specifically in BPD what the average duration of ECMO. I know it would certainly vary depending on if the patient's on VV or VA, and I would guarantee that, or I would bet 99.9%, I would say that VV average course is longer because in general, we support patients on VV much longer. but I don't know the answer to that.
Depends on
I'll just
the
add-
underlying condition, right?
But I would say in the cardiac unit, not necessarily in the BPD population, we have supported patients for months on ECLS before, and particularly BB, and so yeah, they can be on for a long time.
Okay, thank you. All right, so Manby is asking, Brenda, when you change into your prolonged eye times and large tidal volumes, and I guess this leads on to Summer's amazing management plans. Do you update your management plans as you go along? So I guess it's an evolving process, isn't it?
Yeah, I mean, I can't take credit. I think that was a group effort, but I think that the idea that Phil mentioned is it's a regular discussion about changes in the management plan as the phase of care changes. And I think recognizing at 32 weeks that you have evolving chronic lung disease, I think some of your ventilator strategies will change between, somewhere in the 32 to 36 weeks. By 36 weeks, you're just saying you have established BPD at that point. But yeah, I think the idea is that you have that constant evolution. And I even think that the candidates thinking about ECMO and the etiology for why a patient would wind up on ECMO, but also the phase of care that the patient is in would also be factored into determining the reversibility of their disease. I think when you're in have a baby in the convalescent phase who develops a viral infection, that's different from a baby who's really never stabilized and come to that convalescent phase. So I think it's still relatively, new in the field to think about ECLS for these patients. I think ECPR is also another challenge in these patients who have prolonged hypoxia in the NICU, where ECPR is not something that's frequently done. So there's a lot that changes as patients' conditions evolve. But I'll kick that back to Phil as well, because I know that he has really implemented some of this in his unit.
Okay, thank you, Summer. Maybe Phil, you could take that on and then answer Arvin's question as the last one. He's asking about the left heart phenotype. What can be done?
Sure, yeah. I think Arvin has done a lot of work on understanding the left heart, both in severe BPD and pulmonary hypertension. I think, I'm a physicist by training, so in pulmonary hypertension, it's mean pulmonary artery pressure equals pulmonary vascular resistance times pulmonary blood flow plus the pulmonary artery wedge pressure, so plus the left heart disease. I think preterm babies are just at a higher risk to develop systemic hypertension, which can impact the left heart back up to the left atrium into the lungs. I think with the risk of pulmonary vein stenosis, which occurs in about 1% of all babies with severe BPD. So what can we do? The first thing is you have earlier identification of the disease process. You have optimization of ventilation, optimization of sedation, nutrition, and all the non-pharmacological approaches. There are some people who are looking at different methods to do some offloading of the afterload like they do in the CICU world. There's not a lot of great data on that, but conceptually it makes sense to allow the heart to contract and relax without the increased SVR. But I think overall, the optimization, the early recognition that left heart disease can occur, and it may not occur in the neonatal period. It may actually occur in infancy or early childhood when they get COVID, for example, or they get a pneumonia. So it's also following them up because these babies will present as children into the cardiac ICU for Monique, and then they'll present in early adulthood. And it's just a long-term follow-up. We don't have great methods to treat that left heart disease, but we are definitely trying to look more at diastolic dysfunction, things that Kurt is looking at, to really be able to characterize this phenotype. It's really in its infancy, part of my use of baby terminology, but we have more to learn on this and more to learn from our cardiac ICU colleagues. Great question.
Absolutely. Well, we are now 4 minutes past the hour. That was wonderful. What a team effort. Well done, guys. That was fantastic. Just wondering whether it's possible to have a copy of what Summer shared with the management plan. That would be really helpful, I think. Is it out in the open or is it a restricted document?
It's in the paper that we can share as well.
Yep, that would be great if you're okay with sharing the seminars paper. So the audience will get an idea of what to look out for. Do you mind if I gave them your email addresses for them to ask you some more questions? Because I think they probably have a lot to ask and it's getting a bit too late for you.
Fantastic, thanks.
Is that okay? Yeah. Thank you so much. We'll look through the recording, make sure everyone's behaving in the background, and share it to our group.
Thank you so much.
Thank you once again. That was an amazing talk. Thank you so much.
Thank you.
Thank
you all.
Thank you very much.
Thank you.
All right.
Thanks all
Have a
for
good
attending.
night. Bye-bye. Bye,
you.
everyone.